We're going to start off with Dr. Searles, then Dr. Awad, then myself. And so, Dr. Searles, take it away. Yeah.
All right, let's see if I can figure out how to advance these. Perfect. All right. So then I'll be presenting the first case. This is Dr. Hansen's slide deck, and so he put all this together, so appreciate the slides. I do appreciate that he assumed I didn't have any financial disclosures, which I do not. So the first case is a 72-year-old female. She presents for a cataract eval. We have some information about her here. So it says that she enjoys reading, sewing, playing games on a device, gardening, and watching TV. She's ultimately become frustrated with her level of vision, has noticed gradual decline over time. And so this is her base exam. So her vision is uncorrected is 20/70 in that right eye, J2, and 20/50 J1 in the left eye. Here's her refraction. I won't read it all to you, but she's 20/30 in the right corrected and 20/40 in the left. And that's her IOP. And so just hearing that base exam, what are you guys thinking in terms of lens options for this patient? Thoughts?
First question you want to ask her is as far as lenses go, how much does she mind wearing glasses? And is she looking for options to decrease the need for glasses? And she's a low myope, so you always want to be a little extra cautious about the discussion because she's used to having a little bit of myopia helping her out there. So is she doing her near vision activities without glasses already? That kind of leads you down one path. And so those are the kind of the initial things off on my head.
Sure. And so, yeah, so basically, she is interested in getting out of her glasses and contacts. She has worn multifocal contacts in the past and tolerated them okay, she says, and has done monovision with just one contact lens in one eye. And then does that steer you towards one thing or another? Does that change your conversation?
Yeah, I mean, the use of previous multifocal contacts for me is the biggest push towards a multifocal IOL. And then she does a lot of crafts, I forget what, like sewing or something like that, outside gardening. And so this patient here, I would definitely steer them away from monovision because they didn't do very well with I asked why they didn't do well with the contact. If it's vision-wise, not the fact that I don't like putting it in or comfort, but it's probably comfort, or it's probably not comfort, it was the vision component of it. So this one strongly, I'd lean towards a multifocal IOL.
And so we kind of talked about that. And so at this point, there's just so many options for IOLs. We're trying to kind of tease out what patients' interests are, what their hobbies are, what they currently do, where their refraction is currently starting out. And so this is kind of how we think about it in terms of either monofocal IOLs, which either can be the standard one that's not astigmatism correcting or astigmatism correcting, and then talking about different target distances, so whether they want distance or near or some type of monovision, or a presbyopic or premium IOL, things like a multifocal or extended depth of focus lens, or that light adjustable like we've talked about previously. And this is just a schematic of what those lenses are trying to do, whether they're focusing at one point or discrete separate points, or an extended depth of focus that's trying to kind of create an extended depth or a range of focal points kind of close together. And so this is just a flow chart about presbyopic correcting IOLs, whether you're trying to get a full range of correction with that IOL, how tolerant they would be to glare and halos, because we know that multifocal or trifocal IOLs do have glare and halos, and all patients will have glare and halos. Some may not be bothered by them as much as others, but all of them do have that. And then kind of putting that together with whether a multifocal or extended depth of focus is kind of what they're looking for in the presbyopic correcting IOL range. And then there has been some discussion before about the light adjustable. The light adjustable lens gives you some version of monovision plus in some amount of extended depth of focus. And so just more about the presbyopia correcting lenses. So that multifocal lens has discrete focal points. With that, you are splitting the photons or separating the photons that are coming in. So there's always going to be some loss of quality of the vision, some contrast loss. And so it gives you the most independence because it gives you that biggest range of vision, but you're giving up something with that too. extended depth of focus is trying to find some happy medium of not having that much contrast loss, but not getting that much presbyopia correcting. And so maybe that's good for some patients who might not be tolerant of those glare halos or decreased contrast. And so at this point, there's just a huge array of IOL options. There's so many to choose from. It makes the conversation difficult. It makes patients' decisions difficult. It's just hard to kind of match one to a specific patient. And so with that, these conversations about lens options, you're really trying to match what will make the patient the most happy. You're taking a whole bunch of factors, personal factors, their eye health factors, what they do, where they're starting at, what they've been used to, and trying to tease all of that together currently to try to match them with the lens that would work best for them. And so that's where this Greenman device comes in. Again, I don't have any financial disclosures. I don't have any interest in this company, just an interesting idea. And they actually do have a booth out there. But it's a VR headset to try to have patients try out different lens options and different target options. And so that they have some idea about what they're kind of getting themselves into, in a sense. We can talk to them constantly about different lens options, what their vision will be like, but it's different to actually kind of try to experience it. And so what this tries to do, I don't know if this will play at all. It's a VR headset that the patient actually wears. It has two handles that they can actually interact with their environment. And so there's a couple of different scenarios. One's in a living room or kitchen area, and one's nighttime in a car. And you can either put it with the lights on or lights off. And so you get some sense of, if I do a astigmatism correcting for the distance, what is like true full presbyopia of not being able to see clearly up close? What are the glare and halos like with multifocals? What does a monofocal lens do? And so this just allows patients to kind of try it out. Talking to the booth out there, they say it's best for patients who are best corrected as 20/40 or better, because at some point there's enough degradation in the cataract that this becomes less useful. But at least it gives us another data point about trying to steer patients in a lens option that would be best for them. And so you can interact with your environment and kind of hold things up closer, see where kind of the focal points of things are. It's just kind of an interesting concept that's trying to show the rings and halos that you get. And so this is just a slide about the contraindications to multifocal lenses. It's not necessarily that each of these are absolute contraindications, but you're trying to predict, or essentially trying to predict what patients would be happy with after surgery. And so each of these things are just a check mark in one direction or the other of whether they're likely or unlikely to be happy with a certain lens. And so none of them are kind of hard and fast rules necessarily, but they may hold more or less weight when deciding about IOL options. And that's the case. Any other comments?
One comment I want to make about multifocals is there is a group of patients that you want to screen for that, for example, wear their multifocals for a lot of things, but they take them out for certain things. And so what I tell, like for example, if they're going to drive at nighttime, they wear their glasses. Most of them don't have a separate pair of contacts, but they wear their glasses. So you kind of want to ask about that type of thing. Most of them will tell you that they, tell you spontaneously about that, or you can see that in their notes from before when they've tried out contact lenses too.
And another point. We've talked about this before, that this is an educational process that we're working through. It's not just the one moment in the clinic with the surgeon. And the thing that really helps is when you guys tell us what you think might work well for the patient. This is a patient, multifocal contact lens wearer, would do great with multifocal IOLs, potentially, had an early discussion with them. Patient is a monovision contact lens wearer, patient likes low myopia. Those kinds of little blurbs that you can put in your notes to us are golden. We value those so much, because that leapfrogs our discussion forward in terms of the things that you guys already know about the patient that could potentially help us get a really good outcome for them.
All right, thank you. We'll go on to case number 2 here. And, all right, so this is a case number 2. This is a patient who has worsening vision blur and a gritty ocular sensation in both eyes. So it's a 66-year-old male who was referred actually from the retina clinic for cataract surgery because they had a vitrectomy. Pars plana vitrectomy was done 6 months prior in the right eye. But the patient said that the vision was getting worse in both eyes. The glare was getting worse in both eyes. And both eyes were actually quite irritated, particularly on the left, though. We'll go on to the examination. So the ocular history was just significant for the prior pars plana vitrectomy and epiretinal membrane removal 6 months prior in the right eye. Medical history was significant for cholesterol, seasonal allergies, and they were taking cholesterol medications and some steroid nasal spray. Uncorrected acuities were 20/60 on the right and 20/40 on the left. Refraction shows myopia. They actually had a myopic shift larger on the right eye than the left. And then the pressures were measured, this is with our technicians, measured with the eye care at 17 and 19, and measured with applanation at 20 and 32. I'm going to go on to the exam here. So the exam showed actually a thick pterygium on the left, and these are actually just stock photos. These are not actually this patient, because they're different eyes. I do have the pentacams from this patient. So the pterygium was thicker on the left, small pterygium on the right eye. Both eyes had 3+ nuclear sclerosis. The optic nerve looks similar in each eye with a cup to disc of 0.4, and the retinal exam showed a epiretinal removal on the right. I'm going to go over pentacams here, maybe ask the panel to make some comment on the pentacams. We have the unique situation being a referral practice. I actually see the pentacams first before seeing the patient, so I've gotten to the point where I can tell what's happening just by looking at the pentacam. It's not as colorful as the oculoplastics, but it's our crystal ball. You guys want to make a comment on the right eye pentacam at all?
Yeah, so the right eye doesn't look too ugly in terms of the axial topography. So that's the upper left-hand picture up there, and you can see there's a little wisp of blue nasally, kind of from the smaller pterygium. But the central cornea region is fairly uniform and not really impacted by the pterygium over there. So it's not a super scary corneal picture on this right eye.
Beautiful. And then the left.
Dr. Searles?
Yeah, Dr. Searles, please.
Sure. So, I mean, it's kind of similar, just with a larger nasal flattening area, which we presume is from that pterygium.
Yeah, beautiful. Yeah, so when I see this, I see the nasal flattening, increase in front elevation, and increase in thickness. And that, to me, that's pathognomonic for a pterygium. So even if I hadn't seen the patient, we know it's a pterygium. One of the other, the pentacam puts out all sorts of data, and one of the data points is the central 4mm corneal higher order aberrations, which if it's over about 0.300, that means that there's some distortion in the central cornea. So on the first eye, it was basically in the normal range, and on the left eye, it was, it's affecting the central cornea, even though it's not in the central cornea. All right. Oh, are we doing audience response?
I think so.
Yeah, we have an audience response question. I'm just sorry, it's a little hard to read there. I'll go ahead and read them here. So what would be the most appropriate next step in the management of this patient? A, aggressive ocular surface treatment with amniotic membrane and LipiFlow. B, schedule bilateral cataract surgery as soon as possible to address visual complaints. C, refer for glaucoma workup and possible treatment based on elevated IOP readings. D, obtain more history of environmental exposures related to pterygium development, and then clarify the patient expectations for cataract surgery. E, proceed with cataract surgery on the better eye only and reassess the other eye postoperatively. Or F, immediate pterygium excision without further discussion.
And these
Do we
I'm
have
not
it?
sure, I'm not sure if we have it loaded, so let's do a show of hands. How many people would say A? Nobody? B? C? D? E? And F.
Wonderful, wonderful, wonderful. All right, well, that was kind of fun, a little new school and old school mixed in there, so. All right, and Dr. Harden, can you
Well,
give some comments on what would you say next?
Yeah, so factoring along what D is, I would ask them what bugs them the most. So like in this patient here, it's not too hard to start them on some dry eye type of therapies, and I think probably what's bringing them to you is the decreased vision in the right eye with the rapidly advancing cataract after their vitrectomy. But to make them happy in the long run, you're going to have to address their dry eye, their blepharitis, and maybe the pterygium in the left eye. So I don't always, like the cataract-pterygium ratio here, it's about half and half, I think, in the left eye, and the cataract-pterygium ratio in the other eye is like 90 to 10.
Yeah.
And so I would start them on ocular surface improvement therapies, get the cataract out on the right eye, see them back again. They're not going to be highly anisotropic, so you got time on the other eye, and then decide on the other eye if the pterygium bothers them enough to go through surgery. That's kind of how I would approach this patient, because most of the patients that come to me with pterygium of that extent and that amount of irregular astigmatism, they come to me when they've got a 20/50 cataract. And so I can get them within a couple weeks, I can get them, if they're okay wearing glasses, I can get them back to wearing glasses again and not having to do anything about the pterygium and not going through that big long recovery of a pterygium surgery. And so, and that's kind of what we do in cases if that was a 20/60 cataract in the left eye and that amount of pterygium, I'd just take the cataract out. If they are still quite irritated, then you could always go back and take the pterygium off later and kind of, with the typical lid hygiene, tears, cyclosporin type medications, you can get the pterygium not to progress, and if they're still symptomatic, then you take the pterygium off later. That's kind of how I would manage this patient.
Yeah, excellent. That's slightly different than what actually happened, but I totally agree with that approach. It's perfectly acceptable. So in the initial history, we were actually communicating through a Cantonese interpreter, and this patient had spent much of his earlier life in a climate closer to the equator in Asia. And in terms of their expectations, they just wanted to be able to see better. They felt that both eyes were affected with their vision. They were not concerned about being glasses free, but just really wanted to be able to see better. So I guess we talked a little bit about this already, whether we would do cataract surgery alone or combined with pterygium, timing of pterygium excision, lens implant options. Dr. Reeves, do you have any additional comments you want to add to
Yeah,
what?
I mean, again, it's back to expectations here, and the
Yeah.
expectations here are lower. But I mean, if the patient's like, I don't want to wear glasses, then it's like they're getting the pterygium surgery, so that's going to happen. And it's really, that's what guides the decision process. And so let's just take it down the other route of the patient, is really bugged by all this and really wants to not wear glasses. Then for me personally, I like to try to clump things together. And so I would take the pterygium off first and then recover, then remeasure 4 to 6 weeks, later to get new ocular surface keratometry measurements, and then do cataract. Trying to kind of like maximize the speed of their vision recovery. You could do the right eye first, and then they're seeing great out of the right eye, and then they're sort of unhappy for a long time as you wait for the pterygium to recover in the left eye. So again, it just kind of depends on what the patient expectation is for the course, and you get kind of a spidey sense of that talking to them.
Yeah, absolutely. Excellent. So pterygium development, certainly, as we all know, UV exposure is a primary risk factor for pterygium. It's a degenerative elastotic process, so it can be progressive and it can be recurrent. So if you're going to address that, you have to keep that in mind. And it's important to note that it can cause visual disturbances even before it enters the visual axis. So it's, in this particular case, in the left eye in particular, it's inducing significant astigmatism. Indications for surgical removal of astigmatism, as we mentioned, visually significant distortion or threat to the visual axis. If you need preoperative clarity for cataract surgery or for refractive surgery, you want to remove the pterygium first, particularly if they're looking for a refractive outcome that you want to target. So any large or irregular astigmatism definitely can affect the keratometry readings, which affects the IOL calculations. And in this case, you could see that it was even affecting the IOP readings. When you did applanation with a Goldmann tonometer, which is the 3-point-something millimeter applanation, it was hitting the pterygium and causing an artificially high reading. But with the eye care, it was giving a normal reading. And then again, if a patient is having significant ocular irritation, or the pterygium's bothering them really for any reason, in my book, that's a reason to remove the pterygium as well. And this patient was significantly bothered by the left eye. So what we did in this patient is we removed, normally we would do the worst cataract first, which was the right eye, which had the vitrectomy, but the patient wanted to have both cataracts removed and was complaining of irritation. So we, as Dr. Reeves mentioned, we did the pterygium first on the left eye to allow that time to heal. Then we proceeded with the cataract surgery on the right eye. And while that was healing, the left eye was also healing. We remeasured the IOL calculations for the left eye and then did the cataract surgery on the left eye. You can see here the pentacam pre-op and the post-op on the left eye. So that astigmatism was very significant from this pterygium. Thank you. Yeah, any questions?
We'll tackle questions at the end.
Questions at the
Yep,
end.
Yep,
All right.
thank you.
That was a nice cosmetic cornea case. Like how much pretty that looked before and after. See, we can make corneas look pretty too. All right, so last case here. This is a patient who complains of shadow in their vision. So this is a 78-year-old female, about a month after surgery, cataract surgery in the right eye. And she says, I've got this shadow in the edge of my vision. It's always there ever since surgery, and there's no pain or irritation. Otherwise, she says she can see great straight ahead. Distance is super. She's really happy with that eye and can even see well without glasses. Her past history is remarkable for the right eye cataract surgery. It was a toric IOL. She's got a little bit of cataract in the left eye that's not impacting her vision, a little bit of dry eye. She's diabetic and hypertensive, and is on appropriate medications for those, as well as some artificial tears. So on her exam, her right eye uncorrected vision was 20/25, left eye was 20/40. Refraction corrects to 20/20 with a very minimal prescription on the right, and hits 20/25 on the left with a little bit more SIL. Eye pressures are normal in both eyes. And this is the slit lamp examination of the right eye. And this is the fundus examination of the right eye. So we have another audience response. Raise your hand, I'll read through them here. So next steps for this patient would be 1, artificial tears; 2, update glasses; 3, reassurance and check in 6 months; 4, refer for retinal evaluation; 5, refer to the surgeon for YAG, capsulotomy; and 6, return for LASIK on the right eye. So we'll just take a show of hands. Anybody for number 1?
And actually, this one we have loaded,
Oh,
so
heck yeah.
if they
Then
want to
let's go.
scan, they can scan
Let's
and
go.
enter their
Let's go
answers
scan and
via the
enter.
QR code. Each table should have the QR code paper on your centerpiece, so that's how you can answer this question. It should pop up when you log in there. Is anything coming through, AV crew? You can share the results as soon as we get a few responses. There you go.
Okay, all right, so the almost majority felt like the reassurance and check in 6 months might be appropriate. We'll just click on to next slide here. There we go. I'll ask the panel. Panel, what do you think? diagnosis, next steps, what do you think's going on? What would you do?
What it sounds like is she has negative dysphotopsia, which occurs off of square-edged implants. Real common. I tell the patients that if we tried to use an implant that was the same width as their old normal lens, we would have had to keep them in the hospital for 2 months with sandbags, and they'd have 8 diopters of astigmatism, and they will get used to it. I don't say probably, I just say you will, and then they don't sometimes, but then they come back again. And unfortunately, you know, if you look at some of the papers for people that have done a lot of stuff for this, there's a bunch of different options, but none really work very well. And so the other thing I tell them is like wearing a pair of glasses, or we all have clothes on, yeah. And were you thinking about your clothes till I asked you about that? No, probably not. You know, we put some clothes on in the morning, and then you don't think about them the rest of the day. And so that's what I'm hoping is going to happen for this patient, is they'll get used to it like those other things.
Yeah. Other doctors experience with that approach not working?
Definitely giving reassurance is very, very important, letting them know that it can be a very normal thing, that it typically does resolve with time or become less bothersome, at least with time.
Sure. I guess what I'm asking is that, so I'll just say they come back in 6 months and you've reassured them and they're still really bugged. What then? Okay, we're done.
Yeah.
We're done. Thank you all for coming. This has been lovely.
So pupil size modulation can be sometimes helpful. So sometimes constricting the pupil can help to reduce the internal reflections off the edge of the lens implant. And I've even had a couple patients where dilating the pupil actually resolved the dysphotopsias. And they used atropine for a number of months.
Yeah, I mean, the other surgical options, which unfortunately don't work very well, are secondary IOL. You can exchange it for a different lens material that doesn't have a square edge. So you can exchange it for silicone, or the light adjustable lens may have a little bit less of it, so you can exchange it for that. You can exchange it for a PMMA lens. So we have 7mm PMMA lenses that don't have a square edge, but then you've got scleral incision and sutures, and you can capture the optic up above the capsulorhexis to bring it closer to the iris, and usually it doesn't get better with shrinking the pupil, but like Dr. Awad said, maybe enlarging the pupil. So pupiloplasty, for example, doesn't work. The one piece implants you can't really bring up to the iris with sutures out in the periphery that cause probably too much pigment dispersion, unless it's, this one here is fully wrapped in the bag. It's not toric though, so they should sue you for the fact that you put in the wrong implant. But you can bring the implant up to the back of the iris. But the patients that I've seen are usually those that complained about it and have had 5 surgeries, and now they need a corneal transplant and an artificial iris. So it's just really, really challenging to make them happy surgically.
Yeah, I agree. These are I think all of our least favorite kind of case for that very reason. I've operated on maybe 1 or 2 with a piggyback lens, and they've gotten a little bit better. No one's completely resolved it, but they felt like maybe it's a little bit improved. But it's not always a fix. Any of the surgical options are potentially not a full cure. So dysphotopsia, again, it's bothersome visual disturbances after cataract surgery. And it's artifacts from the IOL interaction with light, which is what the IOL is supposed to do, but it does it imperfectly, of course. There's the positive dysphotopsia, which are the sparkles or the shimmers or the glare halo. Then there's the negative, which is the peripheral shadow. And these patients, of course, you're always trying to make sure that there's nothing else going on. There's not any capsule opacity. Clearly, there's a very nice clear capsule here. Capsule stria causing a Maddox rod effect. Retinal detachment, of course, is the big thing. Oh, I've got a shadow in my vision. We're wanting to make sure that there's nothing ominous going on. But positive dysphotopsia is better understood optically. It's an oblique light source hitting the IOL, causing internal reflections and or interaction with the edge of the IOL. Square edge IOLs have this more so than rounded edge IOLs. We mostly have square edge IOLs because that decreases the risk of posterior capsule opacity. So that's why a lot of the IOLs still have a square edge. Higher index refraction material like acrylic, more so than silicone. The negative dysphotopsia is the sort of the worst of the two. It's the big shadow in the edge of the vision, and they describe it, as you guys know, as this peripheral shadow that's sort of always there. And I always have to kind of act it out for them because sometimes they're talking about it and they don't really understand that you're understanding. So I go like this, and they're like, "Yep, that's it." So it's the less understood, but it's felt to be an illumination gap between the edge of the IOL rays that hit the IOL and those that don't and pass just over the top of it, and it creates this kind of peripheral shadow area. That's always there. Associated more with females, smaller pupils, sharp IOL edges, large angle kappa. There's a lot of associations, but there's nothing that guarantees that you'll have it or won't have it. Again, the treatment for these, reassurance, and most people, I would say, adapt to it over time. Most people, it becomes less noticeable. And I would say a large percentage of my early cataract patients within the first month or two, if you actually ask them about it, I think they'd say that it's there. I don't know, I'm not sure if you guys experience that as well, but if you ask them 6 or 12 months, they would say that it's not there. Peripheral capsule opacification may help you out. Neuroadaptation, of course, is what we're sort of waiting for. Pupil size manipulation, pilocarpine, permonidine may help with the positive dysphotopsia, but it doesn't help the negative photopsia. Thick-rimmed glasses, I think Dr. Harden mentioned that. Those are very stylish these days. So you try to get people, convinced of that, but that's just something to, block that peripheral experience for them. And then surgically, like we talked about, there are options that can be helpful, but we're trying really, really, really hard not to put these people back under the knife on the table. And that is the last, and I think we're almost on the
Yeah,
dot,
you
Hannah.
guys did great, right on the
Yes,
button. So
on the
we
button.
will take a few minutes for people to submit questions, or any that have come in, we can throw right up on the screen. And I'll maybe kill 2 birds with 1 stone. While those are getting loaded, I can share some final announcements. So once the questions are answered, you guys can all head over and enjoy the reception. Everybody should have a couple of drink tickets in the back of your badge, so be sure to grab those tickets out. And then as you leave or head to on your way out after visiting the exhibitor hall and having some refreshments, drop your badges in the bin on the way out. I want to say a special thank you to the ODP Planning Committee, everybody kind of here in the back of the room, and our AV crew. So thank you, everybody, for putting on a wonderful event, and a very special thank you to all of our virtual attendees as well. Do you have some questions there on your confidence monitor?
We just have a single question. What is the expected recovery time for eye comfort post-pterygium surgery? Dr. Wad, with the pterygium case?
Yeah, I tell my patients it's about 6 weeks, with most of the discomfort being in the first 3 to 7 days.
One question. People are ready for a cocktail.
Ready for a cocktail. All right.
All right. Well, thank you, everybody, for coming out to 2025 Perspectives in Eye Care. Have a great afternoon.